let's just look at anaphylaxis treatment. So anaphylaxis treatment essentially is with adrenaline, and the dose of adrenaline depends on the age. So up to 6 months of age, 100 to 150 microgram, which is 0.5 mils of 1 in 1,000 adrenaline. On adults, 500 microgram to 0.5 mils. For the child 12 to 17 years of age, still adult dose. 6 to 11 years, 300 micrograms of 3 mils. So obviously 6 to 6 months to 5 years, 150 micrograms. And surely there's no response. We keep giving the adrenaline, the appropriate dose every 5 minutes on the specialist critical care, the ambulance, team, the rest. And then high flow oxygen should be given as quickly as possible to support the patient. There's typical urticaria plus or minus angioedema. Repeated episodes are lasting over 6 weeks duration. And obviously, you make a diagnosis of an inducible urticaria. So physical urticaria triggered by physical stimulus, recognized triggers, pressure, demographism, delayed pressure, cold, passive, heating, emotional stress, vibration, water, solar. Avoid triggers if possible. Treat symptomatically with increasing dose of antihistamines like cetirizine, 10 milligram once daily, increase to 20 milligrams twice daily, which is 40. Because the effects of anadrol 80 milligrams of 540 milligrams day. So you can do effects of anadrol 3 times a day, 180 milligrams 3 times a day, maybe 4 times a day. Refer to dermatology or immunology, symptomatic with difference, with difficult control, or if cold urticaria is suspected. And if it's daily or virtually daily urticaria, possible angioedema for 6 weeks duration or longer, so chronic spontaneous urticaria. Symptoms more or less lasting 6 weeks or more. So if it's lasting more than 6 weeks, we're thinking of chronic. It as per usual, as per flow chart, refer if symptoms are difficult to control despite maximal therapy. Most resolve spontaneously, 50% within 3 years, 90% of having some reactions can be anaphylactic in type and severity. Patients should prescribe adrenaline, auto-injectors such as EpiPen, if at risk of anaphylaxis. So a typical case of urticaria actually can come in exam. Patient tells you that they have this, itchy rash, and maybe that happens each time they have a cold bath. So you need to be checking the anaphylactic features and difficulty in breathing, facial swelling, tongue swelling, this angioedema. They could have angioedema, which is what we're seeing here, plus or minus angioedema. So they could have angioedema, but even that they're not having evidence of respiratory, compromise or circulatory collapse, for instance, they're not feeling really dizzy, feeling very unwell, and kind of systemically unwell. Essentially, you might have some sleep swelling, some very slight tongue swelling. If they're having tongue swelling, obviously you need to be referring them for allergy testing. And at that stage, they might also, if they are having the risk of anaphylaxis, they need to have the EpiPen, the adrenaline auto-injectors, and they need to be taught how to self-administer. Anyone please to them should also be taught how to recognize signs of anaphylaxis and administered EpiPen while calling the ambulance. So that's what care essentially. Slow management of urticaria / angioedema. Let's have a look at it. For patients with chronic spontaneous urticaria, CSU plus or minus angioedema symptoms requiring treatment. Step 1, self-management on oral antihistamine purchase. Advise purchase of over-the-counter oral antihistamine like cetirizine 10 milligrams daily. Well, you can see that you can actually be increasing the dose as well. Check full blood count, thyroid function, ferritin, and manage accordingly. Cetirizine and fexofenadine are not normally sedating, but advise caution with driving and operating machinery if patient feels sleepy. Now, if symptoms improve with these antihistamines, it's likely that symptoms will be persistent or recurrent. Recommend daily antihistamine treatment for 3 to 6 months, then review. If asymptomatic, gradually withdraw treatment and see if symptoms have resolved. If urticaria recurs, prescribe antihistamines again and repeat process every 3 to 6 months. The symptoms were short-lived and frequent recurrence. Thought unlikely. Recommend treatment to be taken as required or prophylactically. And if you use the antihistamine, if there's an inadequate response, increase cetirizine dose 10 milligrams twice daily, increasing the dose at weekly intervals up to 20 milligrams twice a day. Off-label using the loratadine is not superior in efficacy, but can sometimes be better tolerated than cetirizine. It can also be trialed at doses up to 4 times the licensed dose. Now, if you still have an good response to this increased dose of antihistamine, change antihistamine to fexofenadine and titrate up to a max of 540 milligrams per day off label. Usually dosed at 360 milligrams in the morning and 180 milligrams in the evening. I can always do 180 milligrams 3 times a day. For severe unmanageable episodes, consider an emergency pack of prednisolone, 20 to 30 milligrams once daily for 5 to 10 days duration. The background medication should also be escalated. And if maximal background medication is reached, the patient is still symptomatic, referral should be considered. Long-term use of corticosteroids for more than 10 days should be avoided. Because for more than 10 days, I should start thinking of slowly of tapering it off to avoid an additional crisis. If there is significant angioedema, despite maximum use of antihistamines, prescribed tranexamic acid, so you can see tranexamic acid, which is an antifibrinolytic agent, can be used in angioedema. Wow, I never knew that. Never knew that again. Prescribed tranexamic acid 1 gram 3 times a day. Off-label use titrated out to 1.5 grams up to 1.5 grams 3 times a day. Whoa, that's a large dose. If angioedema is not controlled, the dose and dose interval reduce if GFR greater than 50 or if 7% is more than 120. Allow 4 weeks to assess response. Patients should want to report visual symptoms, especially halos around the eyes, which would warrant ophthalmology referral. Patients taking tranexamic acid long-term require full work on UNAs, EGFR, electives, human services. Okay, so it's the GP probably wouldn't even be very confident getting to the stage of prescribing tranexamic acid without having fed his patients on allergy clinic. You know what I mean? If the patient is not really tolerating, antihistamines at high doses, it's not tolerating the short course of prednisolone. At that stage, I should be referring the patient for an allergy testing, not to an allergist specialist, allergy specialist. Tranexamic acid, at such a dose, for how long? It's off label, you know what I mean? Probably wouldn't be confident to take up the responsibility of prescribing tranexamic acid for care. And if I pick the allergy team and it's something I see that they get to recommend for several patients, then I can start doing that. And let's move. If inadequate response, even with tranexamic acid, prescribe 110 Lucas 10 milligrams at night of label, which is a cotrimoxazole. I'd rather try 110 Lucas than even tranexamic acid. But anyway, it's good to know that tranexamic acid can be used and can be tried. Now, if inadequate response to tranexamic to montelukast, refer to immunology and allergy service, also dermatology for constitution of omalizumab, so immunotherapy. Omalizumab is to be prescribed in secondary care only, but tranexamic you can prescribe in primary care for urticaria and angioedema. It's quite good to me that we have that option. I'm just wondering how tranexamic acid will actually work in that aspect, an antifibrinolytic agent, isn't it? Okay. Yeah, similar thing, tranexamic acid. But there's something called pharmacology. Let's look at pharmacology for the management desensitization of bee wasp allergy. So pharmacology and desensitization of bee. So pharmacology is recommended as an option for the treatment of IgE-mediated bee and wasp venom allergy in people who have had a severe systemic reaction to be a wasp venom, or a moderate systemic reaction to be a wasp venom, and who have one or more of the following. People who have a raised baseline serum tryptase, a raised baseline serum tryptase, a high risk of future stings, or anxiety about future things. So it's anxiety about future things, or they've had really severe, or people who are really prone to having exposure to bees and wasps, people that work in bee farms, for instance. The treatment from our GSU initiated and monitored in the specialist center experiencing venom immunotherapy. Margin B wasp, B Margin B venom extract has a marketing authorization for the treatment of IgE mediated allergy to B venom. Margin wasp venom extract has a marketing authorization for the treatment of IgE mediated allergy to wasp venom. So B and wasp are different. Their venoms are different. Treatment with Pharmacology is in two phases, an initial phase and a maintenance phase. Before people receive pharmacology treatment, IgE-mediated allergy to B or wasp must be confirmed by case history and by in vivo and or in vitro diagnosis. Pharmacology is given by subcutaneous injection, so you need to eliminate an IgE testing for either the B or wasp phenol. During the initial phase, an increasing dose of margin is given until the maximum tolerated dose is reached. During the maintenance phase, margin is administered at a dose of 100 micrograms every 4 to 6 weeks for at least 3 years. The dosage may be adjusted depending on the person's history of allergic reactions and sensitivity. So the patient might come in the SCC and they want desensitization for maybe be worse family. Yes, okay, here. Why do you think you need these? What exactly, how much do you know about this desensitization? What exactly are you expecting of me? Have you got any particular concerns as regards these things or wasp things? Any previous exposures, just listen to them. And cross check how much they know and then explain. If they're having an acute urticaria or they have chronic urticaria, what medications are they on? Antihistamines, we tried antihistamines. If they were managing, we try some short course of prednisone, so no allergy, just the tranexamic acid is an option. And then this for margin, they're asking for sensitization, you have to inform your margin is, that's what if margin obviously can only be prescribed by a specialist in an allergy service. Not something that you'll be prescribing as a GP and family physician. I don't know what family physicians in the US do anyway. I would really like to find out how their scope of practice is in the States. ABCD score for stroke or TIA. Well, ABCD scoring is no longer valid, it's no longer advised. Anybody who has had a TIA we should be thinking of anticoagulation. Yeah. So we skip that. It's no longer advised. NICE guideline doesn't advise the use of ABCD scoring in TIA assessments anymore. So let's skip that. Prevent or suspected meningococcal meningitis before during transfer, hospital transfer. There's so much information on this website. I actually feel proud of myself to have compiled all this information on this website. Feel happy, something I feel proud of. So we will suspect meningococcal meningitis means you're giving penicillin injection. Typically, you'll be giving it in primary care by intramuscular injection. You can still give it if it's a child, especially if it's an adult, you can give it but in primary care, we don't usually have cannulas. So most times we'll be giving it by IM injection anyway, with some local anesthetic to reduce the pain. So if it's an adult, 1.2 gram of penicillin. If it's a child who is 10 years and above, adult dose 1.2 gram. If it's a child who's 1 to 9 years old, half of that is 600 milligrams. If it's a child who's 1 month to 11, so an infant, 300. So for neonates, for anyone who is an infant, 300. milligram, and 1 to 9 years, 600 milligram, and above 9 years, so 10 years and above, like over. So this is also something you need to know. A single dose should be given before urgent hospital transfer. So as long as this does not delay the transfer, if there's a history of allergy to penicillin, then we should be thinking of cefotaxime injection. Cefotaxime, which is cephalosporin, can typically be given by intramuscular injection in primary care. So for an adult, it will be 2 grams. Same thing in child 16, 17. Yeah, 2 grams. A child 1 month to 15 years. 50 milligram per kilogram, not enough to that. So we have to dose it based on child's weight, actually 50 milligram per kilogram for the weight. Can still go up to 2 grams, which is the adult dose. Now, a single dose can be given before urgent hospital transfer, so long as this doesn't delay the transfer to hospital. Or if a history of immediate hypersensitivity reaction, including anaphylaxis, angioedema, urticaria, or rash immediately after administration of penicillin, or to cephalosporin, that would be used clinical injection. And for adults, so for both adults and children, with 12.5, 25 milligram, or in the SCA, obviously, but thinking meningococcal meningitis on the history and everything, you just need to be starting, or you need to be knowing benzyl penicillin. If the person has a penicillin allergy, they will be thinking of cefotaxime. Nothing to say, well, I have allergy to cefotaxime. Yeah, by the STA, we should know that we shouldn't do those of penicillin. The age cutoff as well. So treatment of unstable angina or an NSTEMI or NSTEMI before or during hospital transfer, we're thinking the patient has an unstable angina, which is also called a crescendo angina. Essentially, is angina. So the person previously used to have angina, and on exertion, when that person is having either angina at rest or worsening chest pain on exertion. So it's like worsening chest pain on exertion. So unstable angina, for unstable angina, we would be prescribing for unstable angina. Typically, you want to prescribe aspirin. So for an adult, 300 milligram aspirin plus GTN spray or GTN tablets. So the GTN tablets is used sublingually. The spray is also used sublingually. So it's not an oral one, sublingual, because you want it to be absorbed as quickly as possible. So 1 or 2 sprays repeated as required. The tablets as well, and 1 or 2 or 3 tablets depending on. So if it's 300 microgram tablets, you can use it up to 3. But usually 1 first. And a treatment of STEMI, which is ST, so I put double parentheses there. So you can take one off. Treatment of STEMI before and during hospital transfer. So myocardial infarction, ST segment elevation. Now, same thing, you give aspirin, 300 milligram tablets. Person has to drink it by mouth, or it can be chewed, dispersed in water, or chewed. GTN spray or GTN tablet, so same thing, then antiemetic, intravenous metoclopramide injection, diamorphine. In primary care, you don't have access to cannulas intravenous, so in diamorphine, so pain relief so diamorphine and morphine by slow intravenous injection. Oxygen factor. I believe a cannula should be available in the emergency box anyway, so you should still be able to put in a cannula in case of an emergency. Treatment of seizure before during hospital transfer. The convulsive seizures, including febrile seizures, lasting longer than 5 minutes, use either diazepam or rectal diazepam. So it still needs liquid azolam, or you can use midazolam or the midazolam to become midazolam by vocal administration. So for adults, maybe 10 milligrams, repeated once after 5 to 10 minutes if necessary. Without unlicensed, typically, that is vocal midazolam. Check it to see anything. So treatment of crew before during hospital transfer or prednisone is alternative. So for crew, typically we'll be using dexamethasone, but if dexamethasone is not available, then prednisone can be used. And for dexamethasone, typically it's 150 microgram per kilogram at a single dose. So oral dexamethasone, 150 microgram per kilogram, single dose. Is not available, that will be using oral prednisolone syrup, or the liquid prednisolone for children as well. So cool. Treatment of hypoglycemia during hospital transfer is like the diabetic hypoglycemia. Fast-acting carbohydrate glucose is preferred. So things like oral glucose liquid or glucose tablets. The glucose tablets can be used, vocal administration. The glucose gel can be given vocally. So vocal administration, glucose gel, essentially glucose gel or glucose, the glucagon injection. There's no glucagon injection written here. And so is there note examples of glucose preparations can be used to give oral doses as based on the use of oral liquid containing glucose to 15 milligram per ml and tablets containing 4 gram of glucose per tablet. Vocal dosing is based on tubes of 40% of oral glucose containing glucose 10 gram per tube. If hypoglycemia is unresponsive, or if oral route cannot be used, you're giving oral glucose, either the gel or liquid, the drink, or giving glucose tablet, and the patient is still hypoglycemic. You need to keep using your glucagon, glucagon pen. So glucagon injection by intramuscular injection, 1 milligram for adult dose. For a child who's less than 9 years, 8 years and below, you should get of 500 microgram, just have 3.5 ml, yeah. If hypoglycemia is prolonged or responsive to glucagon after 10 minutes, then you'll be thinking of intravenous glucose nutrition. Hopefully by the ambulance will have arrived and you need to have a way to set this up. Now, there's some contraindications to phosphodiesterase 5 inhibitors, in terms of using it to treat erectile dysfunction. So, contraindication is to sildenafil with things like active gastrointestinal bleeding, active gastrointestinal ulceration, cerebrovascular. So the reason why, because the phosphodiesterase 5 inhibitor, phosphodiesterase essentially it catalyzes the reaction that produces prostaglandins, isn't it? What am I even saying? Yeah, that produces prostaglandins. Phosphodiesterase. I think I'm getting confused there. Active gastrointestinal, anyway. Active gastrointestinal bleeding or active gastrointestinal ulceration. You don't use sildenafil because it will reduce the prostaglandin protection in the stomach, isn't it? Yeah. Cerebrovascular disease, inflammatory bowel disease, ischemic heart disease. I actually knew of ischemic heart disease, to be honest, mild to moderate, and but I didn't really know that you shouldn't use sildenafil if in IBD, like Crohn's. I didn't know about that. I didn't even know about this gastrointestinal bleeding and ulceration. Wow. Because clearly the ischemic heart disease aspects, I knew that very much. Um, especially if the patient is on nitrates already. The person is already on nitrates. Cautions, allergic disorders to sildenafil, cardiac impairments, and says may impair renal function. The patient has coagulation defects, connective tissue disorders, dehydration, risk of renal impairment, elderly patients, history of cardiac failure, history of gastrointestinal disorders, hypertension, left ventricular dysfunction, minimal symptoms of infection, edema, risk factors. So one thing that is very important here is a patient in SCA exam could come with weak erection, describe it as impotence, and they might tell you that maybe they haven't tried any medications, and if you can connect, which is even of you, it's always an option. But then being able to identify comorbid factors that might actually make use of phosphodiesterase 5 inhibitors, contraindicated. So you have to ask him there has he got any other medical history, any history of heart problems, any history of blood in his stool, stomach ulcers and things like that. So you need to be asking specific questions in that regard. Assessment and management of stable angina. Management options in patients with a definite diagnosis of stable angina within sign Scottish Intercollegiate Network. So define diagnosis of stable angina, because chest pain, ventral or left side chest pain is worse with brought on exertional chest pain. Pain could be radiating to the left side, to the left arm, shoulder, neck, and the bladder. So angina relieves some rest. That's what's so you have a clear history of angina, introduce or increase. So if the patient is not already on nitrates, anti-agenal therapy, then you need to introduce, which is GTN spray typically, or increase anti-agenal therapy, reduce secondary prevention. So in terms of those patient needs statin, those patient need aspirin, because the patient should be on aspirin actually, should have angina. You should be on aspirin 75 milligram once a day and also having GTN spray. And the question is, does this patient need longer acting nitrates like isosapine mononitrates? So is the patient suitable for risk stratification with functional assessment, e.g. exercise tolerance tests, myocardial perfusion scintigraphy, stress echo, perfusion, cardiac magnetic resonance imaging? If the person is not suitable, then you have to optimize medical therapy. The person can't be suitable for further risk classification investigations. The person is intermediate or low risk, optimized, but in high risk, invasive coronary angiography. So just know that invasive coronary angiography is an option. The person is suitable for revascularization, then you do a PCI or cabbage. The person is not suitable, optimized medical therapy, there are ongoing symptoms, and consider treatment for refractory angina development. Continue medical treatment and medical treatment, obviously, with the UZ or antiplatelet agents, considering statins. The patient should be on statin. Someone has stable angina should be on statin. Thinking of that stage, or thinking of secondary prevention, cardiovascular prevention, because angina is already in ischemic heart disease, isn't it? So the person should be on statin, should be on antiplatelets, or aspirin, then should be on the GTN spray. If the person carries on having symptoms, you understand them on regular nitrates and isosapine nitrates. You can always optimize the dose of that. Let's look at this literature here. The following recommendations were highlighted by the guideline development group as key areas of updates that should be prioritized for implementation. Diagnosis and assessment. CT coronary angiogram should be considered for the investigation of patients with chest pain whom diagnosis of stable angina is suspected but not clear from history. So if you're suspecting whether 100% certain from the history needs to be arranged, referring to cardiology for the CT coronary angiogram. A patient with suspected stable angina, the exercise tolerance test should not be used routinely as a first-line diagnosis. So now stable angina and non-cardiac surgery. The routine use of aspirin to reduce perioperative cardiac events in patients undergoing non-cardiac surgery, including those with non-stable coronary artery disease, is not recommended. Investigation of patients with suspected angina. Yeah, history is the key component in the evaluation of patients with angina. Often the diagnosis can be made on the basis of clinical history alone. Characteristics used to determine the diagnosis include nature and location of the discomfort, the duration of and relationship to exertion, as well as the precipitation or relieving factors. Based on the history, patients can be categorized into three groups: patients with a clear history of stable angina definite, patients with some features in the history but angina suspected, patients describing non-cardiac chest pain, non-cardiac. The following algorithms are suggested for the investigation and management of patients with definite angina or suspected angina, and patients with non-cardiac chest pain do not require further investigations. This is definite diagnosis of angina. So if you suspect angina, that is where there's a diagnosis of uncertainty. You need to be referring for a CT coronary angiography, which anatomical investigation to determine the presence of obstructive coronary artery disease. If there's no coronary artery disease, you discharge from cardiological. There's non-obstructive coronary artery disease, commence secondary prevention medications, no further cardiac investigation required. There's obstructive coronary artery disease, left main stem, or severe three vessel disease, within non-invasive coronary angiography. If the person is suitable for revascularization, they do PCI, percutaneous coronary intervention, or cabbage coronary artery bypass grafts. If is not suitable for revascularization, what will make them not suitable for revascularization? That's the question. Maybe because they have severe heart failure, or revascularization could lead to reperfusion injury, for instance. And optimize medical therapy, ongoing symptoms, consider treatment for refractory angina. More on management of stable angina. More on management of stable angina. So anti-anginal drug therapy. Acute attacks of stable angina should be managed with sublingual GTN, which can also be used as a preventative measure immediately before performing activities that are known to bring on attack. For long-term prevention of chest pain in patients with stable angina, beta blockers such as atenolol, bisoprolol, metoprolol, propranolol should be given as first-line therapy. So for long-term prevention, a rate-limiting calcium channel blocker like verapamil details should be considered as an alternative if beta blockers are contraindicated. For example, in patients with Queen's metal angina or the convoluted heart failure, dihydropyridine derivative calcium blockers amlodipine may be effective in patients with Queen's metal angina. If a beta blocker alone fails to control symptoms adequately, combination of beta blocker and should consider. If this combination is not appropriate due to intolerance or for contraindications with a beta blocker constitutional and neither recommends contribution of addition of long-acting like ivermectin, currently rhinolazium. The long-acting nitrates, ivermectin, nicorandil, rhinolazium should also be considered as monotherapy. So long-acting nitrates such as ivermectin, nicorandil, rhinolazium. So here we can see that they've not mentioned statin and aspirin. Statin and aspirin are prescribed. But anyway, so the thing here is that patient GTN spray typically will be what will start. And the person carries on having those angina, stable angina, and beginning of starting a beta blocker to control the heart rate and reduce myocardial oxygen demand, essentially. That's what we're trying to achieve. We could use a calcium channel blocker, a rate limiting calcium channel blocker, or we could use combination of both if the patient carries on having symptoms. Isosapine mononitrate is used. Let's have a look. Let's have a look. Yeah, prophylaxis of angina, adjunctive conjunctival feeling. So prophylaxis of angina, exactly. So it's a nitrate. initially 20 milligrams 2 to 3 times a day, or alternatively initially 40 milligrams twice a day. Increase if necessary up to 120 milligrams daily. We can always start our aspirin monohydrate and optimize that. Optimize that, which is good. Just going to look. Absolutely. Yeah, cardiovascular disease, secondary prevention. Yeah, so the patient needs to be on aspirin or clopidogrel. So that's what we need to be thinking about. Cardiovascular secondary prevention, especially when it has ischemic heart disease. So really, the patient should be on 75 milligrams of aspirin or clopidogrel for secondary prevention. We should also be thinking of statin for secondary prevention. First, patient should be on statin for secondary prevention because they can very rapidly progress to unstable angina. And then, it's because what we're trying to do here is that the GTN spray will open up the coronary vessels, isn't it, to cause a coronary vessel dilation. The if you have it works actually GTN spray or it actually causes systemic, then that reduces the myocardial oxygen demand, I think. Then same thing with the beta blockers and the rate limiting calcium also reduce the heart rate, reduce the myocardial oxygen demand. But they wouldn't prevent if there is atherosclerosis within the coronary artery, they wouldn't prevent progression of the atherosclerotic plaques. That's why we need to be prescribing statins and aspirin to prevent progression from stable angina to stable angina or from myocardial infarction. So then we need to be prescribing secondary, cardiovascular prevention alongside that. And if we progress further, let's look at this just in case medications used in palliative care. So the just in case box, and really what it is just in case is a step above when a patient who is palliative begins to have distressing symptoms, we begin to consider PRN, parenteral medications, and that's where the just in case comes. The patient now has need for continuous symptom relief parenterally, then we now switch into a syringe driver, a syringe pump. So suggested medications that could be included in standard just in case packs for patients without COVID. I'm sure we added without COVID because of the COVID pandemic. 2 ampoules, so essentially morphine sulfates for pain, breathlessness. So levomethomazine for nausea and vomiting, midazolam for restlessness, anxiety, agitation, breathlessness, haloperidol for nausea, vomiting, hallucinations, agitation, hyoscine bromide, which is buscopan, or hyoscine hydrobromide, or hyoscine butyrbromide, or glycopyrronium, so antimuscarinics for respiratory tract secretions. So you can put hyoscine, glycopyrronium, respiratory tract infections. So all of these should be present within a just in case box or bar. And then usually the district nurses or the palliative care nurses will be administering these medications when the patient or the relative, call them out and say, well, this patient is having lots of pain, their regular tablets are not controlling the pain, or they're becoming more agitated, having some nice type hallucinations or things like that. We need to do this, and if they carry on having those frequent symptoms, then we need to be discussing a syringe drive, and we'll be giving continuous infusions, subcutaneous infusions of these medications. Now, care of the dying patients, checklists. If they refer to your local care of the dying resources, review current medications, discontinue non-essential medications, focusing on comfort care. So end of life care, essentially. Prescribe when required subcutaneous medications, which is just in case. Assess the need for a syringe pump to deliver necessary medication. Establish the patient's wishes so the patient have an advanced care plan where their preferred place of care and also preferred place of death. Consider a treatment escalation plan, resuscitation decision. Consider additional support the patient and family might have or might need, for instance, hospice at home, chaplaincy, care, sitters, explain your decision making and plans to the patients if with families, can keep them informed, review the patients urgently, regularly, document your decisions, plan and discussions, update the electronic palliative care coordination system for out of hours information. It's very important because, as a GP surgery, you have patients on palliative care, you need to know them. But when your GP surgery is closed, the out of hour system needs to also be aware of these patients. So the electronic palliative care coordination system, for out of hours information, needs to update that. So we'll continue for the next week, we continue from psoriasis management.